diagnostic laboratories in countries such as Zimbabwe, Botswana, and South Africa, and has also worked as a biostatistician in different organizations. In 2014, he joined MSF as a research coordinator for the Zimbabwe project. He then joined MSF SAMU unit in 2016, where he works as the epidemiologist and laboratory advisor for Sub-Saharan Africa and Asian countries. So you can see he's a well-versed scientist, and we welcome Mr. Ndlovu to take us through. Mr. Ndlovu, sir.
Thank you, Dr. Chibemba, and good afternoon to everyone joining. So I hope everyone can see my slides and can hear me audible. So basically my talk today will be more or less to share with you experiences from MSF as we scaled up advanced HIV diagnostics. Ideally, as HIV epidemic is maturing, our health systems more or less should be able to also quickly evolve to identify patients with advanced HIV disease who are at high risk of mortality. So the take-home message from this talk literally should be for program managers at national level, funders, partners, to be able to scale up advanced HIV implementation of advanced HIV diagnostics, or either to continue where they have already started. So starting with my PowerPoint, which I'm hoping everyone can see the content more or less, I'll give you a background of advanced HIV, and we'll go on to talk about experiences of MSF, and lastly, we'll speak about advocacy for advanced HIV. So as a background, according to UNAIDS, in 2018, we had 770,000 people who died from HIV. And this is literally a mere decrease of 30,000 people if you compare to 2017. So it means year on year, there's very limited impact or reductions in deaths from HIV. And this, of course, when you try and then superimpose this with the UNAIDS global estimates of 500,000 deaths that we more or less are supposed to reach in the year 2020, this year with our 1990 goals, ideally we're supposed to be having 135,000 reductions in deaths, but we're sitting on 30,000 at the moment, as you can see from the. So the idea now is to ensure that we try and deal with the fourth 90, which is mortality reduction. So now coming to advanced HIV, what exactly is advanced HIV? In 2017, WHO released a guideline that defined advanced HIV as an adult with a CD4 less than 200, or clinical stage 3 or 4 at presentation to care, or all children basically under the age of 5. So someone could ask and say, but aren't things getting better with increased ART coverage together with the test and treat and dolutegravir use? Are we not going to treat ourselves out of this advanced HIV disease that we're seeing? So unfortunately, part of the answer is yes, coverage is increasing if we reduce the burden, but at the same time, we still see a lot of people who present for ART with very low CD4 counts, less than 200, as you can see there. And again, on the other side of the coin, people who are already on ART experienced, we're seeing a significant number that present with advanced HIV, showing that there's a lot of disengagement and re-engagement to care. Now, this slide is from Cape Town. It's from one of the Western Cape programs, national programs, and it shows basically in yellow there, as you can see, that the evolution and composition of people who have advanced HIV, we more and more have people now who have exposure to ART, as you can see from the top yellowish color. This next study that I put there is from Sergio Carmona in South Africa, and also it shows the proportion of people who initiated ART. It's a recent study from 2018. It shows us that 32% of nearly over 1 million people who initiated ART in 2017, in 2016 presented with advanced HIV. Again, this is another study from Zimbabwe by Simon and colleagues. It shows about 47% of people initiating ART had advanced HIV, and so on and so on. That one is also from West Africa. But the last highlight I want to bring out to you is this study also from DRC and Kenya. This one looked at patients in IPD setting who are admitted in a hospital setting. So we had nearly 83% in Kenya and 97% in a referral hospital in DRC who had advanced HIV. And of course, among those, 70% were ART experienced. So we have a mixture, when you talk of advanced HIV, we have a mixture of patients who are experienced on ART and also ART naive. And bottom line is that patients with advanced HIV are at a high risk of mortality. And the question now is, what do they die from? What causes the mortality? And these 4 graphs are from 4 different countries where MSF has implemented some activities. As you can see, the major contributor to mortality is TB. There's also cryptococcal meningitis. There's severe bacterial infections. There's Kaposi sarcoma. There's PCP. So now we'll talk more in detail now the kind of framework we implemented to try and reduce this mortality. As already mentioned, in 2017, WHO released the guideline that more or less clarifies the package of interventions that programs need to implement. And the package of care includes screening tests. The basic package is composed of CD4 test, urine tubulum, and the CRAG test, as you see in red there. But again, there's also inclusion of treatments and also prophylactic medications together with intensified adherence support, which in most cases is one of the weakest links in many programs. And the question now is, who should be screened for advanced HIV? It's everyone at ART initiation. It's also everyone who re-engages to care after they have been lost to care, which has been piloted in many sections by MSF and other partners as a welcome back service to try and re-engage those who have been on ART prior but disengaged. And also everyone who's seriously ill. This is WHO stage 3 or 4, together with all children less than 5 years of age and HIV pregnant women. They should be screened for advanced HIV. So in a nutshell, this slide shows us again that CD4 still remains a critical diagnostic test for identifying ambulatory and asymptomatic patients who are eligible for further testing for advanced HIV. So in a nutshell, CD4, of course, will trigger any CD4 less than 200, will trigger urine tubulum, and CRAG. CRAG is a cryptoantigen test, a test for identifying cryptococcal meningitis. So in a way, we can see the relevance of CD4, even though we have decreasing numbers, as you will see in the next slide, decreasing numbers of CD4 happening in different projects. So the next question is, where are the patients with advanced HIV? Where do we find them? And how then do we screen and manage them? So ordinarily, from the community level to getting to the primary care head level, that's where you have a lot of patients with advanced HIV, but most of them are well. They don't have any symptoms. And at hospital level, by the time they reach hospital level, they are in advanced state where mortality is very high within 48 hours. So all these 3 places are very important for advanced HIV, and we will have to be able to implement different schemes of the packages to ensure that we catch patients in all these different tiers. And last but not least, we should also take care of discharge of patients from hospitals where we have seen mortalities of up to 30% because there's poor linkage to care after advanced HIV patients are discharged. So bottom line is that we need to be able to ensure that the whole tier of care is taken care of when we implement these packages. So despite the fact that we have the WHO guidance from over 2 years ago, and despite the growing awareness of advanced HIV, we still have very low uptake and demand for this advanced HIV package. Now, getting deeper into experiences from our projects in MSF, so we have different projects in Sub-Saharan Africa and some in Asia that have been focusing on advanced HIV. So I'll try and more or less distill the experiences from these different projects. So we'll start with community level. What have we been implementing? Firstly, in community level, we've been focusing on ensuring that there's adequate and reliable ART distributions. These include your differentiated service delivery models that are more or less are going to reduce the burden that we see in health facilities in terms of patient workloads, especially patients who are not supposed to necessarily come to the health facilities. The other key thing that we've learned from is the need to ensure that you educate the patients on danger signs about HIV and issues around stigma. There's need to continue, of course, advocacy around stigma reductions. And lastly, eliminating barriers to testing care, ensuring that there's easy accessibility to testing in our health facilities and also in our decentralized facilities. At primary healthcare level, this is one of the most crucial points that advanced HIV diagnostics and patient management must be scaled up, because ordinarily this is the first point of seeking care among patients who have HIV. And of course, from our experiences, we saw that on-job training of clinicians to ensure that there's improvements in their skills for screening for opportunistic infections was very crucial, especially the triage process where patients need to be triaged, danger signs screened, and ensure that by the time either a patient is referred, there's clarity into probable causality of the illness. We know that in most of our primary healthcare levels, it's either there are no laboratories and there's no laboratory trained staff, but this advanced HIV package of care is easily implementable, even when there's microscopy sites, as you can see, or even within the ART room. So our experiences, we have seen that in primary healthcare facilities where there's basically even an ART room, as you will see in the next slide. When I say an ART room, it's just a facility where within the clinic where patients get their refills for ART. So what we have seen from our experience is the fact that we had lay cadres who were task shifted to do the testing, and the testing was more or less based on a two-way system, both on a reflex test system and also a provider-initiated system. So patients will come and queue within the ART refill rooms, and any patient who clinically is not looking well will be asked to go to the room where there's the testing personnel, in this case the lay cadres, and CD4 testing will be done, and everyone testing for CD4 less than, testing with CD4 less than 200 will be offered, of course, CRAG and LAM, and LAM is based on a urine, and CRAG, of course, based on the blood. So what we saw as a working and a key enabler is the effect of task shifting at primary healthcare levels, because most clinicians and our nurses are more or less overwhelmed with work, especially in facilities that haven't more or less implemented differentiated service delivery. So with advanced HIV screening, you need urgent results. These patients are liable to be lost to follow up, and they have a high risk of mortality. So results that are coming back within a few hours, at most 2 hours at most, are crucial. So this is one of the key things, as you will see in the next slide. I will explain in detail how the lay card has worked. And of course, any positive result from urine TB LAM, TB treatment is commenced together with, for CRAG, any positive CRAG LAM, there's preemptive therapy that's given. And of course, there's a bit of referral that will have to be done. In addition, like I've already said, patients and community support is very crucial, and it's been very weak in many cases. And I've already mentioned the welcome back service that more or less is crucial for re-engaging those who have been lost to care. So this slide in summary more or less gives us some of the key enablers to within a primary healthcare level. Now getting into detail about this package of care, as you can see, CD4 testing is more or less the trigger, especially for asymptomatic patients. And we use different platforms. It could be a PIMA, it could be a BDFAX Presto. We've also recently piloted the Omega. And those, if the CD4 is less than 200, those reflex trigger urine TB LAM, as you can see in the picture, and also CRAG LFA. But besides this, the clinicians can also voluntarily ask for these tests, and the healthcare worker the lay cadre will quickly do the test, as I've already mentioned. And also, I think I've already mentioned the effect that the cornerstone of advanced HIV screening programs is a quick result. It will be no use if the patient has to go back home, and we know that in most cases loss to follow-up is pretty high, and we know that the patient is in high risk of mortality. So quick result is crucial. As you can see in red there, in our projects at secondary and tertiary level, we more or less had results come back within 60 minutes. This is from sample collection back to the clinician having the results. And in PHC levels, time more or less varied, but it was less than we had in secondary level facilities. Again, I would like to emphasize that there's very limited uptake of this minimal, and I highlight the word minimal. This is a minimal package that is easily implementable from primary healthcare level, as you will see, going to upper secondary level. And again, I also put these other pictures to just let you know that there's different many tools also for CD4 screening, but also for facilities with resources. They can also have a gene expect is also recommended by WHO. Now, getting deeper into this task shifting that I've already mentioned, yes, nurses and clinicians can do this advanced HIV screening, but we have seen, like I've already mentioned, that they are in most cases overwhelmed by a lot of patients where differentiated service models haven't been implemented for refills. So from our experiences, we have seen that utilizing a specific lay cadre to be responsible for these tests at a primary healthcare level, together with quality assurance, together with stock monitoring of these tests, could facilitate rapid and quality results. And this more or less, for us, it wasn't an issue of creating a new job profile, because we've already seen also in many of these projects where we support the Ministry of Health, that the Ministry of Health normally has these lay cadres who could act as people to do this testing. For example, in Malawi, there's health diagnostic assistants who are doing a good job, and lay counselors in other countries. In other countries, there's nurse assistants, facility navigators. All these different cadres could be given the role to help increase coverage of advanced HIV screening. And last but not least, not try to sound a bit panicky, but failure to have sufficient human resources could, of course, result in severe underutilization of advanced HIV tests. This picture is from one of the MSF-supported primary healthcare clinics in Malawi, in Sanje. It shows the room I was mentioning to say, within the clinic, there's a refill room where patients come to get their refills, and then next to it, there's a small room. As you can see, it's pretty small. This is where all the screening is done by a lay cadre. As you can see in the picture, there's a PIMA machine there. And again, also the arrow pointing down is showing cards that are for drying DBS and EID samples. So the lay cadre will do the CD4s, the crack, and the urine lump, but also be responsible for other tests like rapid HIV test and collection of DBS samples for EID and viral load. And also on the wall there, you can see there's some charts that this gentleman does put his statistics, how many were done in a month, and issues around quality. So in a nutshell, this specific cadre in this specific site in Sanje district, this is a rural cohort which has got about 2,300 in this specific clinic. It's got about 2,300 patients on AD. And the lay cadre does about 100 to 140 CD4 tests per month, together with, of course, the urine and the TB lump. And patients with CD4 less than 200 out of these in a primary healthcare facility like this varies between 10 to 15%. And of course, as you will see in the next slide, the positivity of LAM and crack also varies, crack being about 5% and LAM being plus or minus 10% or so. Now, for patient support, I think I've already mentioned the need of patient supported in many facilities and in many national programs. There's limited investments in this, but it's super crucial for healthcare workers to understand the challenges that patients face, especially patients who re-engage to care and come back to care. So in most cases, we assume that we know what is making the patient not take the treatment. And in most cases, patients end up, of course, giving up because there's little investment in understanding the challenges that they have. What we see is literally a tip of the iceberg, but there's a lot of investments that are needed in patient support. Now, moving to secondary healthcare level facilities, what did we do? Of course, I've already mentioned the fact that in secondary healthcare levels, mortality is very high after within 48 hours of admission. And of course, we need rapid investigations and patient management. Just like in the primary healthcare facilities, there's reflex testing, but in this case, it's at the laboratory level because most of our secondary healthcare facilities have laboratories. But together with laboratory-based reflex testing, there's also provider-initiated testing. And on top of this, we also went ahead and piloted what we call rapid assessments units, which are more or less subsections of the emergency department in secondary sites. But the idea is to more or less equip healthcare workers with tools, further test, and ensure that patients who come with advanced HIV are quickly attended to. By the time they're admitted, there's clarity on the underlying morbidity causes. As you can see again in this picture, we can see that, of course, clinical skills are pretty relevant. On-job training, clinician mentoring to ensure rapid patient investigations. And we can see in the other picture there, again, that's in a RAU in one of our projects in Malawi, and you can still see there's a picture. On the picture, you can see that there's also some point of care devices. That's a PIMA and that's a HemoQ, and always emphasizing is the fact that you can also have these tests at point of care. And again, at point of care within a secondary facilities, you can even have even more tests other than just the basic package. It's advisable, of course, to have more of these tests, and of course, availability of drugs is very crucial. Now, talking about post-discharge, as I've already mentioned, is very crucial, and we have seen that there's up to 30% mortality. It's super crucial that active follow-up of patients after they are discharged is in place to ensure that there's continuation of treatment, to ensure that support for patients to understand danger signs, and that support again and linkage to health facilities should need be is very crucial. So for us, this was also one of the key enablers. Now, just to summarize on this table, I'm showing you statistics from different countries in terms of our testing coverage, but this just shows a few of the countries, not all of the countries. But what I want to highlight here is the fact that in blue, the numbers in blue are representing testing that more or less happened at primary healthcare level, whilst the ones in black, it's partly in secondary level and partly in tertiary healthcare levels. But again, as you can see, overall, the proportion of patients whom we found having advanced HIV varies. You can still see in red some places where as high as 70% and some, which of course is a referral HIV facility where the proportion of patients with CD4 less than 200 is pretty high, and it's pretty low, of course, like I've already explained in primary healthcare sites. And LAM positivity, as you can see there also, and varies together with crack positivity. So in our projects, one of our goals was to ensure we minimize patients being referred to secondary facilities unnecessarily. The idea was to ensure there's a safety net of screening all patients in primary healthcare levels, investing a lot of resources there to ensure that you don't overwhelm your secondary health facilities unnecessarily. Hence, a lot of our work was in primary healthcare level, but we tried to ensure that the whole continuum of care is a lot of activities. I've mentioned the turnaround time being very crucial. I know in different countries, there's different models that have been implemented, but the key issue is to ensure the result comes back on time and the patient is traced and given proper management. So one crucial factor that I'm going to re-emphasize again is that, yes, we have scaled up viral load testing and there's been substantial decrease in CD4 testing, but we need to re-establish that coexistence of both those two important platforms. This slide, I'm not going to talk too much about it, but it more or less summarizes the framework and the building blocks for implementing the advanced HIV diagnostic, starting from whom to test, which we have already on the extreme right column, which we already mentioned that, and also where to test. And you can see the background black arrow pointing up. It more or less, in a way, shows where majority of these patients will be found, which of course is in primary healthcare levels, and the need to ensure that within those lower level tiers, there's a whole lot of screening that is done there. And of course, we have spoke about what tests to do, the middle row, but I tried to put in black at least the minimum package. And of course, depending on resources and availability, all these other tests could be made available. Now, the question is, have we seen any success so far in implementing this? I'll give you a half-baked answer. Partly, yes, we have seen a lot of success, but the other thing is at primary healthcare level, it's very difficult to measure reductions in mortality because patients are discharged. There's no way of following them up and knowing ultimately what the outcome could be. But this is just a slide showing the outcomes from a HIV referral hospital. It's an MSF referral hospital in DRC in Kinshasa. We have seen reductions in mortality. And this, I'm talking about patients on second and on third line ACT. We've seen, and also on DRTB, I mean, having DRTB, we've seen reductions in mortality. We've seen significant increases in switch to second line ART, together with decreases in case fatality rate from TB. Now, coming out of MSF and probably reflecting on where most or where some national programs are, of course, we've seen that as a result of test and treat, together with the use of viral load for monitoring ART, a lot of CD4 testing has literally fallen off the priority list, as we all know. And this is a graph from Zimbabwe that has shown the evolution and the successive increases in viral load coverage. As you can see, the orange line is showing the successful increment in viral load coverage, which they've been done very well. And then, of course, CD4 is going down, which, I mean, is a case in many countries. Investments have been towards viral load. And of course, now the question now is, we still need CD4 for advanced HIV. And the question is the need to balance the two. And as I've already mentioned, that we can't rely, of course, on clinical screening alone, because it misses nearly 50% of patients. So our program managers at national level, together with partners, still need to rethink of how to re-optimize these platforms. Most of them are white elephants in our laboratories, but they more or less need to be re-optimized to see how best placement could be done. MSF, together with partners, we have formed an Advanced HIV Consortium. We have different partners. We have CHAI and other partners. More or less, we conducted a survey in 2018 and 2019 just to assess and see the availability of policies in different countries and the progress in procurement of advanced HIV packages. And these are the countries which we more or less assessed just to see where countries are. And we produced a report which was more or less released at ICASA in December. And what we found basically when assessing where countries are is that many countries at that time did not have any policy that included advanced HIV, a bit understandably because their policies were developed before the WHO guideline of 2017. But my colleagues in CHAI have been doing a lot to help the scale up and the mentoring of different countries, and also the development of the guidance. And the other thing we saw from that survey that we did is the fact that there's still a high pricing for certain commodities like flucytosine for crypto, and also some of the diagnostic tests, of course, remain fairly expensive. And of course, there's a need to lobby and not advocate around that. And the other finding we saw was the fact that funding is not yet available in many countries. It could be domestic funding, it could be international partner funding. And like I've already mentioned, CD4 testing is now more or less been out of the priority in many settings. But the good thing that we found is the fact that many countries have been transitioning to dolutegravir within their first line. That report is available on that link. It's quite nice to read it and see where countries are, and it could help to more or less develop a base for advocacy. Now, the other thing worth mentioning is from my colleagues in CHAI. Like I've already mentioned, they are doing a lot of mentorship on scale up on advanced HIV in different countries with support from Unitate. And in their recent market analysis report, they showed that, of course, CD4 testing will fall down in the short term, but by 2023, they modeled that the demand will still be plus or minus 10 million CD4 tests done globally. So, of course, it calls upon the need to refocus and for us to put our energies again to CD4 network optimization if we are to see elimination of AIDS as a public health threat. Now, one of my last slides, of course, is going to talk about the advocacy, because advocacy is very crucial in all that we do to ensure that all actors understand where we're going and what's needed. So the first advocacy, of course, is around these diagnostic tests. As I've already mentioned, that the test and the treatment are not yet available. Some because of affordability, some because they haven't been registered in those countries, especially some drugs like liposomal amphotericin B and things like that, they haven't been registered. So we still need a little of advocacy around that, ensure tests are registered, ensure tests are procured. At least the minimum package should be there in health facilities from primary healthcare level all the way up to secondary and tertiary. Also, the education materials for patients. Patient needs to understand what advanced HIV entails and these danger signs. It's things they know, but sometimes with different messaging, there's different notions that people might assume that now I'm on dolutegravir, everything is fine, or now I'm not detectable, I may have to stop. So there's a lot of messaging that still needs to go out there, together with capacity building for healthcare workers. And the issue of funding, which I've already spoke of, the need for domestic funding, together with funding that could be coming from Global Fund. And I know PEPFAR in their recent COP guidance did touch a bit on the issue around advanced HIV. And again, in our countries, of course, we need to ensure these mechanisms for ensuring affordability of these commodities. We know it could be transparency in pricing or waiving duties on key products. So there's a lot that we can learn from having come from implementing different packages of care. And also, of course, we still need a bit of advocacy from manufacturers of diagnostic tools. I think in my graph, when I showed you what patients die from in terms of mortality, there was severe bacterial infections. There was others where there wasn't clarity on what exactly the disease is because we don't have diagnostics to enable that quick triage and quick understanding of causes of morbidity. Last but not least, I'd assume that was my last slide, but this is my last slide, more or less to say what were the key enablers for MSF to implement the package of care for advanced HIV. Of course, the key issue is functional triage and referral systems. I can't overemphasize this, which is literally your basic good patient monitoring, which has to be in place. Your CD4, your viral load, together with tracing of those viral loads to follow up, and the task shifting of testing where possible, because this will enable the quick result turnaround and prompt actioning of those results, which is also super crucial. And I've of course mentioned the need for post-discharge follow-up and the need for funding and preventing stock up. So in conclusion, the advanced HIV disease model of care is implementable in all different healthcare tiers. And we should, and it must be priority for our governments, for our partners, for our implementers. I know some have already started implementing this. Some who haven't should consider starting to implement, but those who already have started, they should be able to start scaling this this approach up. And I can't overemphasize the need for task shifting. And of course, the primary healthcare level is very crucial, as I've already mentioned. And our program managers should be able to help draft the framework of how to find the coexistence between CD4 and viral load, because there's of course that kind of need to invest resources in both. Thank you very much.
Thank you very much, Z, for this wonderful presentation. I'm sure all of us are yearning to ask or contribute on advanced HIV disease. I've got a question on the chat. Let me just read that question before we ask the participants to start asking questions. So it goes, within the minimum test package, screening for bacterial infections is not part. And yet in the earlier slide, it indicates bacterial infections as one of the causes of mortality, about 1%, which may be even more. How have you managed bacterial infections among patients with HIV advanced disease?
Thank you for that question.
You can go for this one and then we'll ask the participants.
Perfect. We have severely struggled to screen for bacterial infections, especially to come up to the right diagnosis. So what we have more or less been doing is collecting blood culture samples, but of course, most of our labs in the countries where MSF supports, they had difficulty in terms of the quality of culture. So it's been a difficult process, and we've tried to also use some biomarkers, procalcitonin, CRP, but you find that in our settings where there's high HIV, TB burden, these markers won't give you any specific reliable information. So this is why one of the advocacy slides that, points that I put there is the need to have tests that can easily be used biomarkers to help us screen for bacterial infections. It's still a very big gap, but when I emphasize the minimum package is talking of what at least should be there, which is easily implementable. But we still hope that we can have easier tests to implement in the near future for screening for bacterial infections.
Thank you. Any questions from the participants? Questions, contributions?
Good afternoon, Dr. Siwemba.
Good afternoon.
Dr. Sivile here, my hand is up.
Yeah.
Hello?
You can go ahead, Dr. Sivile.
Thank you very much. My name is Dr. Sivile. I'm the ART advisor for Zambia, the Zambia program, and I'm an infectious diseases specialist by training. I would like to thank the speaker for these elaborate slides, especially that they were more on the implementation side. Here in Zambia, we are just at a preparatory phase for coming up with packages and guidelines for advanced HIV disease. And these slides are so helpful. I hope they'll be shared with us. And in that same line, I'd like to beg that we are included in that consortium of countries, because I think advanced HIV disease is a big problem here. I have two questions for the speaker. The first question is on task shifting. A number of patients who die from cryptococcal meningitis, from TB, I'm sure we know that don't actually die from the infection itself. It's usually the complications of the infection, the hypokalemias, a lot of other things which needs kind of specialist care. So my question is directed to your fourth point on your conclusion. How can we, improve the treatment once it's advanced, HIV disease and, complications are identified? I think these cannot be handled by task shifting. How do we raise the bar, especially in our setting in the low middle income countries? We know that electrolytes, a lot of these other, specialist kind of facilities are not readily available. The second question is on the M&D process. This is at the programmatic level. What are your recommendations or advice on how to build a good M&D framework for advanced HIV disease, or if there are any best case scenarios, I think you can share that with us, especially at the national level, because here in Zambia, the M&D processes for advanced HIV are non-existent. Thank you very much.
Thank you, Dr. Sivile. I think we'll take another question before Z answers them. Another question, please.
There's another one in the chat box from EOA.
Hi, this is Fabian from Zimbabwe.
Okay.
Yeah, this is Fabian. I work with CHI Zimbabwe. Just a question to see on your experiences, especially on the diagnostics side, mainly for CD4, the products that are available. Do you feel like we have like the adequate diagnostics, or they still need for more innovations around CD4? Also, I think as we look at the current distribution of CD4 devices, or even the products that are already on the market, especially if you look at things like the fax calibers, which are big and usually like at the central and bigger hospitals, would there be a need to shift probably to smaller products, like, for example, the POC ones, and what would be your advice, especially on innovations for CD4?
Thank you very much. I think Z, you can attend to those three questions.
Okay, thank you. I'll probably start with Dr. Sivile's question on the consortium. So I'm not sure if CHI, I'll probably have to refer you to my colleagues in CHI if they can still add you to their consortium on mentoring different countries. But I know they started mid last year. I'll probably take your details after this and refer you to them if they can include you. And then on the issue of task shifting, so more or less one of the weakest links has been within the screening, and this is why when we say task shifting for screening, mostly it's on using the diagnostic tools. So using the diagnostic tools, this is by the lay cutters to ensure that the clinicians get prompt results. And why we need this is, like I've already mentioned, in different countries where MSF is working, we have tried to also have clinicians, the nurses and the doctors use these tools, but you find that they hardly use them because they are having so much to do. Hence, we thought if the testing is done by a lay cutter with prompt results to the clinician, of course, we have seen a massive kind of impact in this. And of course, I mean, I concur with you that there's a whole lot of complicated cases of patients at primary healthcare level, and sometimes you would need a specialist to monitor the treatments. For example, for cryptococcal meningitis, we have flucytosine, we have injections now, potential recommendations for liposomal amphotericin B. Of course, it's very difficult for these treatments to be managed at primary healthcare level. And again, some of the lessons that we're trying to share is to see how this package can be decentralized. And the key issue at the moment is to ensure a good referral system. A good referral system that links to your secondary and tertiary health levels, but at the same time, to try and minimize unnecessary referrals and try and deal with non-complicated cases in primary healthcare level. I mean, we have seen from our experiences, even patients who test positive for crack and LAM, we will start preemptive therapy, and then we'll refer them to secondary and tertiary facilities for lumbar puncture and things like that. But one, you will see that a lot of patients don't even go to these secondary facilities, or if they go, they will refuse lumbar puncture. So there's need for different ways to try and deal with this. And one of the things we've also been doing is to try and implement the semi-quantitative crack test to ensure that those who have a positive at a higher titer, we ensure aggressive close follow-up within referral sites. And coming to M&E, about the good framework, I think the key issue, of course, is to invest. As long as there is no investment in any M&E systems, I mean, it's going to be garbage in, garbage out. Sorry to use those words, but I'm just trying to portray the fact that if there is no investments in any of this, we won't be able to expect to get much. There's different tools out there in out there that could be used, like TIA.net, but all you want is a system that can longitudinally follow your patients so that you are able to see the evolution of morbidity or different outcomes, and of course have unique identifiers for each patient. Each patient, if they are in point A, facility A, if they appear in facility B, you can still be able to easily pick these patients up. But we see that in most programs, there are no unique identifiers. If they are there, these facilities don't talk to each other. The patient has to be more or less restricted to one area, which of course we know has got its advantages and disadvantages. But bottom line, investment in M&E with good indicators. And then to Fabian, on issue of CD4 products available, honestly, I think if we are to more or less try and look for a pipeline of better CD4 products, we may probably be waiting for a long time before we get anything, because of course manufacturers will also look into the market, and of course as Chai's report shows, the market is still there, but there's potentially limited increase in the market. There will be a stagnation of plus or minus 10 million tests according to that. And for me, currently, based on the tools we have tools, for example, the new point of care semi-quantitative semi-quantitative omega test for CD4 that gives you a CD4 result at a threshold of 200 is one of the potential usable tools at lower decentralized levels. And as you go up the tier, of course, you have your fax Prestos and your PIMAs, and then in higher tertiary and secondary facilities, of course, the fax caliber. I think the good thing and the most important thing is to ensure that our programs have different brands of these tools to ensure competitive pricing, and of course to ensure sustainability. Should one, as we know, some of these devices, sometimes they go through decommissioning or they go through reagent recall. So it will be crucial to have that healthy mix of competitive pricing, different brands, and ensure that devices with a higher throughput are reserved for facilities with higher level. One of the crucial things will be for our project managers to ensure they map where exactly are the highest cases of advanced HIV per district, per province, per setting, and then be able to then position these tools, because we have these machines already in place in most cases. It's just a matter of reactivating them and ensuring that they are in optimal use and not underused, as we have seen in most of our different places.
Thank you. We have something on the chat. Let me just go to the chat so that we can see what has been asked. So the first one is, with reduced funding, how can programs reprioritize advanced HIV disease cases? That's the first one. Then the second is, thank you for the information. Given the several months of LabCoP events targeting waste management sites, will the advanced HIV disease agenda give consideration in their selection of diagnostic choices? That is, when there is a choice, select devices that do not require eventual battery disposal. And one more question from the participants before Z can attend to the questions.
Yeah, Dr. Shivemba, this is Felix Mwanza from Lusaka, Zambia here. Sorry, I joined in late.
Felix, you're welcome.
Thank you very much. Yeah, my name is Felix Mwanza, like I've said. I'm the Director for Treatment Advocacy Literacy Campaign, TAUC. But most importantly, I'm also a recipient of care that has been on treatment for 19 years now. My observation in as far as AHD is concerned is that it manifests at two levels. One is the first level is that probably may not and because of several factors, they have delayed to be initiated creeping in. And on treatment, but because of several factors, they could have access. They resurface, or when they are brought into care, they have progressed, disease, and this could have a lot more co-infections coming in. Now, having said that, what is being done in order to ensure that community support structures for persons living with HIV and civil society-led HIV organizations are empowered, one, to encourage as many positive to be aware that there are these particular dangers that lay ahead. Number two, what is being done to empower people living with HIV-led organizations to follow up on these particular people that fall on treatment, because diagonizing is one thing, but I think we should also play a proactive role in terms of ensuring that we do not reach this particular stage. Thank you.
Thank you, Felix. Z, can you attend to those queries?
Thank you. Let me try start with Felix questions, but honestly, I had probably 15% of what he said, but I will try and probably answer to that. So I think what I heard most was the fact that community structures need to be empowered. And I cannot agree with you more, Felix. This is the crucial part. Like I've already said, in most cases, our health systems respond to problems we have, but hardly involve the communities. And communities, they know the problems that are there, and they know sometimes partly how to solve some of these problems. So without a doubt, we need a lot of investment in community engagement. We need investment in teaching patients how to understand the danger signs. For example, in MSF, in some of our differentiated service delivery approaches where we have CAGs, community ad groups, where a group of patients, they sometimes have only one person go to the facility to get ad for the rest of the group. So what we try and do is to, within that group, the group sits together regularly, they brief each other and help each other understand and be able to understand all these different danger signs that could encroach, and should anyone feel any of those, they are quickly referred to the facility. But again, is the fact of empowering the patients, the recipients of the care. And just to add on to this, most of our programs have very weak systems for tracing patients who are lost to care. And when patients are lost to care, sometimes the attitude of healthcare workers in the facilities is what drives them away, because in most cases, the attitude that sometimes you get is not very good, and there's less listening of patients. So that's why I said also we need to engage and ensure that there's education around healthcare workers, so that the stigma and the language that is used towards patients, because sometimes treatments don't work, and it's because the treatments are not working. It's not the fault of the patient. But in most cases, patients bear the brand of bad labeling and finger pointing and things like that. So I completely agree with you, Felix. There's a lot of work to be done. And like I've shared our experiences in ensuring that within CAGs, we empower patients. We also do more or less video support, but mostly this we've piloted it in TB. But these are things that could be piloted also post-discharge, to have such systems to follow up and to support and to ensure that we reinvent the will to respond to HIV. It's been more or less stagnant at the moment, the way things are, the status quo, because it comes back to our communities having signs about HIV, educating the community, talking about all these things that are there, the new treatments and different things. So I feel like there's still a lot that needs to be done, and it's good that you mentioned it. And then talking about the waste management, yes, I know there's been a lot around waste management, especially when it comes to viral load devices and the waste they have that contains cyanide. But as far as I'm concerned, for advanced HIV, we have these rapid test and lateral flow test, and together with CD4 testing, which, as far as I'm concerned, there isn't any toxic higher level material like the cyanide we used to find in viral load, unless someone could probably correct me. But as far as we are concerned, these more or less the cracked LFA test and the urine lump can easily be disposable in a black bag and then sent for incineration in a centralized facility. So I could safely summarize that there isn't much of a worry of waste management among these. And the last question was asking about the funding to prioritize advanced HIV in the midst of budget cuts. This is a very difficult question, and unfortunately, I can't give you an answer where budgets should come from. But like I've already mentioned, that we have seen evidence of funding that could come from PEPFAR in their COP. There was a bit of some notes on advanced HIV, together with Global Fund. And I've also mentioned that UNITAID has supported CHI and I guess some other organizations on this. But again, the key issue is to be able to have also some domestic funding around this, because partly there has to be some responsibilities also to grow the domestic funding to ensure that there is funding for this. And if you look into the funding, it should cover, of course, your diagnostics, your medication, and of course, advocacy issues. So I'm sorry if I'm probably not giving you the correct answer for this one, but it's a very difficult one. And ongoing discussions with partners probably could help in unlocking the funding.
Thank you, Z. What about the one with the minimum qualifications of a lay cadre?
Okay, I didn't hear that one. Probably it's when I had poor connectivity. But our lay cadres, I think I did mention who they were in terms of their positions, that we had health diagnostic assistants, we had nurse aides, we had phlebotomists. So it's anyone who has a minimum qualification among those that I've just mentioned. So it depends, of course, the country in terms of how does one get to be a phlebotomist, how does one get to qualified as an nurse aide. But the overall aim shouldn't be just to utilize these lay cadres solely for advanced HIV. We have to be innovative, as we have mentioned that resources are becoming slimmer and slimmer. We have to do a lot more with the less that we have. So these cadres, there's different roles that they can partake in. Like I've mentioned in Malawi, that our cadres were also involved in basic collection of samples for viral load, for EID, even for tracing of results. Those are the people who can help us. There's a lot of reinventing the wheel that we need to do with the resources that we currently have. And for us, it was one of the enabling factors, because clinicians, honestly, and nurses, in most cases, could not do these tests as they were overwhelmed.
Thank you very much, Z. I think we've come to the end of our program, and it's been, I'm sure, very successful. And we have about 48 participants. We have had Uganda participating, Mozambique, Malawi, Kenya, Zambia, and Nigeria. And I thank you, ASLM, for according me this opportunity to chair this meeting. And for now, I'll hand over to Anafi. Anafi, over to you.
Okay. Thank you, Dr. Shivemba, and thank you, Z, as well, for the wonderful presentation. Thank you to all of you who have joined this interesting session. Clearly, a lot of interesting discussions. Some questions that are in the chat box haven't been answered, but we will, as usual, take them to the presenter and then get them back to you. We shall share the presentation and the videos. And then a few announcements to the country teams. Thanks for submitting your work plans. I think we have received almost all of them. That helps us to chart our way forward as to what we are going to be reasonably be able to do this year. Without wasting much time, I think let me just say thank you to all and have a good afternoon, good morning, or evening, wherever, depending on wherever you are. Till we meet again, goodbye.
Goodbye.
Thank you.